Welcome to the Lymphoma Research Foundation's Treating Lymphoma with Bispecific Antibodies. I'm Christina, and I'll be the operator for today's call. During today's call, you will hear from an expert speaker, and you will have an opportunity to ask questions. If you have questions during today's presentation, you can ask them at any time in the Q&A box on the webinar. As a reminder, this webinar is being recorded. At the end of the program, a link will appear on your screen. Please follow this link to complete an evaluation of this program. If you're listening by phone, this link will be sent to your email at the end of the webinar. And now, I am pleased to introduce Jessie Brown. Jessie Brown is the Associate Director of Patient Education Programs at the Lymphoma Research Foundation. Welcome, Jessie.
Thank you, and thank you to each of you for taking the time to join us on today's webinar on treating lymphoma with bispecific antibodies. We'd like to thank our sponsors of this webinar, Genmab AbbVie and Genentech Biogen. Before we begin with the program, I'd like to share some information about the Lymphoma Research Foundation. We're the nation's largest nonprofit organization that focuses specifically on lymphoma, and our mission is to eradicate lymphoma and serve those touched by the disease. All of our work is led by our Scientific Advisory Board, which is a group of 45 leading lymphoma experts from around the country. In addition to today's program, we all have a variety of other programs and services available to you. One example is our LRF helpline, which serves to complement our patient education programs. The helpline has master's level trained staff who provide individualized information on all types of lymphomas, as well as information on treatment options, clinical trial navigation, and connections to resources such as financial assistance. We offer a peer support program called the Lymphoma Support Network. Through the Lymphoma Support Network, we can connect patients and caregivers with others who have been through similar experiences for emotional support. In addition, LRF has free comprehensive disease guides and fact sheets, which can be ordered or downloaded on our website, lymphoma.org. We also offer a variety of other in-person and virtual education programming, so you can continue learning about the latest updates throughout the year. And finally, we have an award-winning mobile app called Focus on Lymphoma. This app provides helpful disease content as well as unique tools to better manage your lymphoma. The app is available free of charge in the Apple App Store and Google Play. We have a wonderful program planned for you today with two expert speakers. I'm honored to first introduce you to Dr. Lorenzo Falchi. Dr. Falchi is a medical oncologist at Memorial Sloan Kettering Cancer Center. He is also an assistant professor at Weill Cornell Graduate School of Medical Sciences. Thank you so much, Dr. Falchi, for speaking at our program today. I will now turn the talk over to you.
Thanks, Jessie. Thank you so much to you, to the LRF as a whole, and to all of our listeners and callers today. I'm very excited to be here and to be sharing some of what we've learned and some of what we haven't yet learned, but it's of help to our patients and caregivers about bispecific antibodies, which are a very hot topic today in lymphoma care. And I think that initiatives like this really help us disseminate some of the important information that patients and caregivers really need to have as they prepare to meet with their providers, with their oncologists, and perhaps think about one of these treatment options. I'm also very happy to be joined by my friend and colleague, Dr. Jennifer Crombie, from Dana-Farber, who is going to be speaking right after me, and then we'll be happy to take your questions together. So I'll kick us off with some general concept and some of the more sort of high-level clinical data that I think it's important for all of us to keep in mind as we consider bispecific antibodies as one of the treatment options for our lymphoma patients. So just only two slides as to sort of set the stage. Most of our listeners obviously are familiar with non-Hodgkin lymphoma. It is a sort of an umbrella term to refer to a very large number of different types of lymphoproliferative diseases. There's over 100 different types of non-Hodgkin lymphoma, and collectively, these diseases really do make it to the top 10 of the most frequent, malignant diseases. So it really is a common problem. This is both for, men and women. more importantly, as I mentioned a moment ago, there's really a very, very large number of different kinds of lymphomas. This is a classification from 5 years ago, but the latest classification is essentially the same. There's over 100 different types of them. Today, we're going to be focusing mostly on the B-cell non-Hodgkin lymphomas, this longer column that you see on the left-hand side, because that's where bispecific antibodies for lymphoma have made the most inroads, and also it's where those bispecific antibodies are currently FDA approved. In the pie chart down here on the bottom right, you can see sort of the breakdown of lymphomas. And if you pay attention to the blue kind of slice and the purple slice, DLBCL or diffuse large B-cell lymphoma, and follicular lymphoma, those combined are really the most common lymphomas of all. So this is a type of treatment that the bispecific antibodies are a type of treatment that really encompass two of the most common lymphomas that we encounter. So they have a really great impact on our patients and our lymphoma care in general. And so I'll start with a very simple question, because I think getting the foundations right it really helps us then understand everything that comes after. And so, what exactly are bispecific antibodies, and really what does the word bispecific mean? And to answer that question, we go back to just for one quick second to what antibodies or natural antibodies really are. So antibodies, as you know, are proteins that are made by the cells of our immune system. And these proteins are what allows our immune system to recognize an infection or like a virus or a bacteria as something that is foreign to our body. Therefore, enables our immune system. They enable our immune system to attack foreign entities, such as, again, viruses, bacteria, etc. If you were to look at antibodies that our body makes under a special microscope, you would actually see protein structures like these. These are 5 different kinds of natural antibodies. They're called in different ways: IgG, IgE, IgD, IgM, and IgA. But you can see all of them have in common this kind of Y-shaped structure. And this Y-shaped structure is made up of 2 components. One is called the heavy chain, one is called the light chain. But the bottom line is that this is the ideal shape of this protein for it to be very effective at what it does. And here I listed basically the basic facts of how antibodies really work. You have different kinds of antibodies. Each antibody recognizes one protein in a very specific way. You can think of it as a key on a door. Basically, there's only one key that opens one door, and this is exactly how antibodies work. If you focus on the IgG structure that I circled in red here on the top left, basically the 2 kind of little arms of this Y-shaped protein is where the antibody recognizes this foreign protein, or any protein really. Whereas the stem of that Y-shaped protein is how the antibody kind of calls in the immune system to come and kill off that particular, bacteria, parasite, or virus, or whatever is foreign. Okay, so then if bacteria, viruses, express a foreign protein, then the antibody has been educated and trained to recognize that foreign protein. It calls in the immune system. The immune system destroys that infectious agent. That's how we protect ourselves against infections. This principle has been taken up by oncology researchers to make some of the most effective drugs in oncology, not just lymphoma, oncology at large today. And here's the first example. So from natural antibody, the next step is to make monospecific antibodies. Through a process that I'm not going to go into because it's really complicated, scientists were able to basically make the same protein, Y-shaped antibody, except it's not a natural antibody, it's an engineered antibody, we call it monoclonal antibody because basically we're able to make antibodies that all recognize one protein and one protein only. And this is artificially made. And believe it or not, that part that is engineered into the antibody protein to recognize the antigen of choice, the protein of choice, it comes from a mouse. And so most of you are going to be familiar with rituximab, which is a drug that we all use for the treatment of B-cell lymphomas. Well, that drug is exactly made in the way that you see it here depicted, is a Y-shaped protein where the stem, the green part here, is human, whereas the two antennas, so to speak, that recognize the protein, in that case CD20, which is a protein associated with lymphoma, that comes from a mouse. They get kind of fused together and made in series. But the principle is the same. When this protein recognizes the CD20 on top of the lymphoma cells, it kind of anchors onto it and it calls in the immune system, and the immune system does what it does best. So it destroys that cell. Now, that's obviously not a bug or a bacteria, it's a lymphoma cell. That's how rituximab works. That's how Gazyva works. That's how ofatumumab works. And any antibody for therapeutic use works in the same way. Okay, this antibody is called monospecific. Why? Because both the kind of purple parts here recognize CD20, both of them. Now, one step forward, how do you go from monospecific to bispecific antibody? So here you see it depicted here. It's the same protein, again, Y-shaped protein, except the stem part and really half of the protein as a whole comes from one type of antibody and the other half comes from another type of antibody. Plus, each of these two halves is engineered with a little portion, again coming from mouse, that is recognizing a protein of choice. But because the two halves are different, you can decide which target protein each of these halves has to recognize. In this particular case, and these are the drugs we're going to be talking about in this hour, one half of this antibody recognizes CD20, just like rituximab, whereas the other half recognizes, in this case, CD3. The two halves are kept together by a technology called knobs and holes. You can see it kind of depicted down here. Basically, there's a little outpouching on one half and a little depression on the other half, so that basically the two half proteins are kept together by forces. So what this antibody does, it works completely differently than rituximab. Remember, rituximab recognizes the lymphoma with both his CD20 kind of ends. In this case, you have one end that recognizes CD20, so same thing, whereas the other end recognizes CD3. Guess where CD3 is expressed? It is expressed on your immune cells, specifically on your T cells. Okay, so then you can already imagine how this is going to work, and I'll show you in a second. But this kind of antibody has another engineering marvel, which is at the tail end of it. Remember what I said before. The stem part of this antibody is the one that calls in the immune system to come and destroy that particular cancer cell. Well, here, what the scientists did is they introduced a genetic mutation so that the stem part is actually doing absolutely nothing. Why is that? Because you already are engaging your T cell through the CD3 specific portion of the bispecific antibody. Okay, so then you can say, okay, Dr. Faki, but then how does this work in practice? Well, let me show you. I wish we could have animations because I'd made a really pretty one, but we don't. So you just kind of bear with me for a second here. All right, so you have your lymphoma cell here, which is sort of hanging out in the lymph node. All those lymph nodes that you can see, for example, in a CAT scan that are enlarged, they're full of these lymphoma cells. And each of these lymphoma cells on the top of it, on the surface of it, it expresses a bunch of a bunch of CD20, which is this protein that's kind of a marker of the lymphoma cell. In the same lymph node coexisting with the lymphoma cell, you have the T cells. T cells are part of your natural immune system. And as I said a moment ago, they naturally express CD3, which is this protein that's on top of the T cell. Here, I just put 2 cells for simplicity, but imagine there's, hundreds of millions of these cells in each lymph node. Okay, now I'm throwing in the bispecific antibody in the mix. So what does the bispecific antibody do? As I said before, with one half of it, it attaches to the lymphoma cell. With another half of it, it attaches to the T cell. So now I no longer have to wait for the immune system, or in this case, the T cell, to kind of come by, somehow recognize that lymphoma cell and kill it, because I'm actually actively going to grab it and put it next to a lymphoma cell. So what happens when a T cell gets close to a lymphoma cell? It's exactly like when a bull sees red. It just goes completely nuts and it becomes activated and it liberates a bunch of toxic chemicals and it just literally kills off the lymphoma cell within minutes. I had a micro video to show you. Obviously, I can't here, but believe me, it happens within minutes to a few hours. That's how bispecific antibodies work. Is this an effective way of working? It surely is. If you look at some of the experiments that were done, you can see a clearance of the lymphoma cells within minutes to hours, both in petri dishes, in animal models, and as I'll show you in a second, that proved true also in human subjects in clinical trials. All right, so this is a little overview of the bispecific products that are currently either approved or, as we say it, in development, meaning in clinical trials in hopes to be approved in the near future. The top 3 are the ones we're going to be focusing on today: mosunetuzumab, glofitamab, and epcoritamab. They couldn't find easier names, so this is what they kind of stuck with. I'm not going to tell you the brand names because they're even more complicated. So you can see here the other ones are odronextamab, just to go on easier name, plamotamab, and IGM-2323, which also has a name as of recently, which I can't even spell. But these are the structures of these drugs. You can see they're very similar to one another, with the exception of the last one. We're going to not talk about this too much in this talk. It's also not very developed at the moment. It's in small clinical trials. But you can see the first 5, they really all have the same structure. You remember that Y-shaped structure. They have some variations on top of it. For example, glofitamab here has another little piece on top of one of the arms. Plamotamab has one of the arms folded onto itself. But the basic kind of concept remains the same. And you can see here that the first 3 of these drugs are FDA approved, whereas the other 3 are not yet FDA approved. Mosunetuzumab is FDA approved for the treatment of follicular lymphoma following 2 or more lines of systemic therapy. In other words, when somebody has had 2 different kinds of therapies and perhaps the lymphoma comes back, that's when you can use mosunetuzumab. Similarly, glofitamab and epcoritamab are used for diffuse large B-cell lymphoma, so the more aggressive type of lymphoma, also after 2 or more lines of systemic therapy. And these 2 drugs are really used in the same setting. All right, so just very briefly, 3 slides, 1 each for the 3 FDA-approved drugs, just to give you a sense of the power of these medications. First, how are these drugs administered? Glofitamab is a drug that gets given intravenously. The first time you get it, the infusion is about 4 hours. After that, the infusion is usually typically 2 hours. It's given, as you can see here on the top left, during the first few weeks on what's called a step-up dosing schedule. In other words, you're first going to get a small dose to kind of prime your immune system and make sure the drug is safe to give. That's followed by an intermediate dose, in this case 10 milligram. And then as of the following week, you go on to the full dose, which for glofitamab is 30 milligrams. The drug is administered once every 3 weeks up to a total of 12 cycles, which is approximately 9 months of therapy. This is a time-limited therapy. After 9 months, you stop. And you can see here in the clinical trial that got this drug approved by the FDA, this was a relatively large clinical trial. We were participants in this clinical trial, over 150 patients. These are some of the characteristics of the patients. And I just want to point you out to a couple of these. These were patients who unfortunately had a disease that had come back after a number of different lines of therapy. Some individuals had 4, 5, 6, 7 different types of therapy. So very difficult diseases to treat. And about a third of our patients in this trial had CAR T-cell therapy, which most of you, I'm sure, are familiar with. Very powerful type of therapy, but not effective for everybody, and disease can come back after CAR T-cell therapy as well. You can see here that over half of the patients in this study had a response to the treatment, and almost 40% of them had what's called a complete response, meaning you do a PET scan and you cannot see the lymphoma anymore. So that's a great result. And it's hard to interpret from this kind of graphs here, but basically I'll interpret it for you. When you see a flat line towards the end of this graph here, both at the top and at the bottom, that means that after a while, although some patients unfortunately still experience a recurrence after glofitamab, some of them did not. And some of these patients were followed out for a number of months, sometimes a few years. We're always very cautious in using words like cure, but you certainly have patients who are free of disease 2, 3 years. I certainly have some of these patients that are disease-free 2 or 3 years out without signs of recurrence and doing really well. So I'm very hopeful that I'm not going to have to treat some of these patients of mine anymore. So that's the first great study that we cover. The second is the epcoritamab trial. Very, very similar trial. You could see here again on the top left how this drug is given. Same concept. During cycle 1, you first get a tiny little dose to make sure that the drug is well tolerated, then an intermediate dose before going on to the first full dose. In this case, the full dose is 48 milligrams. One important difference between epcoritamab and glofitamab is that epcoritamab is an injection under the skin, whereas glofitamab is an intravenous injection. Another important difference is that glofitamab is given a lot more often. You can see it here. Each cycle is 28 days long. In the first 3 months, glofitamab is given once a week. In the subsequent 6 months, glofitamab is given every other week. As of cycle 10, I'm sorry, here there's a little mistake. It's after cycle 10 onwards, the drug is given once every 28 days, basically on day 1 of each cycle. So that's the second difference. The third difference is that this drug, in its current FDA approval package, is given until what's called until progression or until benefit is given. Basically, the drug is given continuously for as long as you're benefiting from it. And we obviously don't know if given it for a time limited, for a limited amount of time or continuously, if there's any difference, potentially time will tell. At the moment, we don't really know. Down here in the bottom left, you see the features of the patients that were enrolled in this clinical trial. Very similar size, 157 patients. Again, if you look at the number of prior therapies, the fourth kind of row here, patients had received a number of different therapies, including CAR T-cell again in 39% of cases. And some of these patients had many of these therapies. So it really in need of something to make their situation better. And you can see it up here on the top right, that the chance of response to glofitamab was 63%, and the complete response rate was 39%. So very similar to the glofitamab data, very, very promising results. Again, you see in these two curves on the top and on the bottom that there's kind of a flat tail to these curves, meaning that there is certainly a percentage of our patients, quite significant percentage of our patients, who fortunately were able to maintain in remission without evidence of disease recurrence. And lastly, mosunetuzumab. Now we switch from diffuse large B-cell lymphoma to follicular lymphoma. A very similar concept. This drug, also FDA approved, is given intravenously. It's a little bit of a shorter infusion, usually an hour, but same concept. During the first 3 weeks, you get it every week on a step-up dosing schedule. First 1 milligram, then 2, then 60. Here's a little bit more kind of nuanced because you get it at 60 milligrams twice in cycle 1 and then in cycle 2. And then the dose goes down to 30 milligrams for the remainder of the therapy, which for patients who have a complete response is limited to 6 months or 8 cycles. For patients who have a good response but not a complete response, you can actually be treated for up to a year, 17 injections. Patients on this study, this is actually not 157, I apologize for the typo here, is 90. They had a number of prior therapies. You can see that their responses were very gratifying, 80% response rate, 60% chance of a complete response. And you can see here in the curve also on the bottom right that about 40% of patients, very similarly to the previous studies that I shown, even though this is a different context, about 40% of patients were disease-free and recurrence-free at a relatively long follow-up time, 3 years or so. Here you can also see that the blue curve is better than the red curve, meaning more patients had a good outcome with mosunetuzumab than the same patients had with the treatment prior to mosunetuzumab. Basically, mosunetuzumab outperformed the previous therapies in the same patients. That's how basically the FDA got it approved. I was also asked to essentially tell you where I think these drugs should be placed in the way we think about treating patients with B-cell lymphoma. I think that's a very difficult question. It would take, an entire day to discuss. So I'll just give you a flash kind of point of view on this, particularly for large cell lymphoma. Follicular lymphoma is, believe it or not, it's easier conversation. For large cell lymphoma, as you know, or you may know, the first line therapy is a combination chemotherapy called usually R-CHOP or similar type of chemotherapy. When the disease, if the disease comes back after R-CHOP, usually our second line therapy is either CAR T-cell therapy or some form of chemotherapy with what's usually called autologous stem cell transplantation. Those are your second line therapies, and that remains the case in 2023. Where bispecific antibodies have a role is in the third line, what's called a third line setting. In other words, after these 2 lines of therapy, if the lymphoma were to come back again, that's when you start thinking about bispecific antibodies. I say start thinking about it because you can see it in the box in the middle of the slide. There's a list of drugs that you have available to you, and you and your oncologist have to decide which one makes the most sense at that particular point in time. I contend that bispecific antibodies are among the best, particularly for patients who have had CAR T-cell therapy. But there's certainly a number of different treatments that can make sense. And more often than not, there isn't a right or wrong answer. It's just really what makes medical sense at that time. As far as follicular lymphoma, I don't have a slide, but essentially in follicular lymphoma, it really is about the sequencing of therapies rather than which one you do first. So if your oncologist were to say, okay, let's say you have follicular lymphoma, you've had 2 or 3 different types of therapies, and unfortunately they didn't work out too well. What do we do now? Well, we have, let's say, CAR T-cell therapy, we have an oral medication, and then we have, let's say, mosunetuzumab. It's not that one is better than the other necessarily, primarily because they were never compared one against the other. It's that these treatments will likely be sequenced. So if your oncologist is more confident or comfortable with using mosunetuzumab first, that's what you should get first. If they want to use CAR T cell first, because maybe that makes more sense in that particular case, that's what you'll get first, and maybe reserve something like mosunetuzumab for a later time. So I want to emphasize very much so that there isn't really a right or wrong answer as to when these drugs should be used. For diffuse large B-cell lymphoma, I'd say it's a little bit more stringent, but for follicular lymphoma, certainly much less so. I'm not going to go through this one, but it's just to give you a sense of how many clinical trials are going on that use or include or incorporate bispecific antibodies. It's really a ton of trials, which is a good thing, good news for all our patients, because it means that research is moving really, really fast. Many of these trials were me and Dr. Crombie are part of, so we're really kind of at the forefront of this, and we're very eager to see what the results are going to be looking like. And then to finish and to sort of hand it off to Dr. Crombie, I've been looking at the sort of the bright side of this, right? I've been showing the results and how powerful these drugs are, how good and how much hope these drugs offer to us. But as you know or may have learned, there's no drug that comes without any side effects. And here I'm basically showing the correlate between the chance of response, so the power of each of these drugs that I covered, against the likelihood of side effects. And specifically, this one side effect is called CRS. You'll hear more about it in the second part of this seminar. And you can see that the more you go up in power, a little bit more the chances that you can get some side effects. Now, we're very good at managing these side effects, and we're getting better and better over time, but they're there, they exist, and it's really important to know they are there, what they are, how they present, and what to do about them. And I think with that, I'll hand it off to Jen to cover the second part, and I think we might get your questions maybe all together at the end.
Yes, that's correct. Thank you so much, Dr. Falke. And I'm now honored to introduce Dr. Jennifer Crombie. Dr. Crombie is a medical oncologist at Dana-Farber Cancer Institute. She's also an assistant professor at Harvard Medical School. Thank you so much, Dr. Crombie, for speaking at our program today, and I will now turn the talk over to you.
Great. Thank you for the introduction, and great for that. Thanks for that nice segue leading into the toxicities that we see with bispecific antibodies, which I will be focusing on. So these are just disclosures. So the part of the session that I'm going to be focusing on are what you can expect from these treatments, and then knowing what to expect, how caregivers can help their family members or friends going through this type of treatment, and then once you enter into the follow-up period of care, what to expect at that point. We'll start with the side effects. So what are the most common side effects? You already heard in the previous part of this talk about cytokine release syndrome. That's really the most important side effect to be aware of with the bispecifics. And if anyone listening in on this call has had or has heard about CAR T cell therapy, they're probably familiar with this entity, but we'll speak about it in more detail today. So cytokine release syndrome is key. And then some other side effects that can be seen with bispecific antibodies include fever. That can be a part of CRS, but it can be seen separately. Fatigue, low blood counts can be seen. And then these are rarer, but some patients may have GI upset with diarrhea or nausea. Some patients may report headache. And so I put the more common ones here, less common ones that I didn't make the list that are probably important to also be aware of, especially with the bispecifics that patients remain on for some time, are the increased risk of infections as well, although this was not common. So, sorry, skipping ahead. So what is cytokine release syndrome? This is an acute systemic inflammatory syndrome, and this can be associated with the cellular therapies that we use in lymphoma. And this is associated with elevated levels of cytokines, which can be markers of high levels of inflammation. So as you saw in that diagram earlier on, when the T cell binds to the bispecific antibody and is activated in close proximity to that B cell, the T cell can fight the B cell, but in that process release these cytokines. So while it's a good thing, if it's overactivated, it can result in this high inflammatory state that can have side effects for the patients. If patients develop cytokine release syndrome, the most common presentation is fever, but in the more severe presentations, patients can also have low blood pressure, they can have chills, they can have fast heart rate, and then again, more severe forms can also affect the patient's oxygen level. So I think it's worth understanding how we as the physicians think about determining the severity of CRS, and this is the formal grading system that we use, and this applies to both CAR T cell therapy and bispecific antibodies. So a grade 1 would be just a fever alone. So if you hear us talk about how many patients had grade 1, that's really what we're referring to, that the patient had a fever. A grade 2 would be fever, but then also having effects on the blood pressure or oxygen with lower blood pressure, not requiring medications, and then also low oxygen levels, potentially requiring a low level of oxygen. And then grade 3 and 4 imply that the patient needs higher level of support with medications to support their blood pressure, and then higher amounts of oxygen as well. So that's what we're talking about when we talk about the grade. So I wanted to walk through each of the FDA approved agents that we have now and talk about what you could expect in terms of the rates of CRS and other side effects that we're seeing. So I'll start with mosunetuzumab. As you heard, this agent is FDA approved for patients with follicular lymphoma. So across this study, it was seen that 44%, so less than half of patients, had cytokine release syndrome, and the majority of patients had low grade, so mostly grade 1 and then some grade 2. And so that means that the patients really were just having fever. Some patients had fever with low blood pressure, and it was very rare. Only 2% of patients had the more severe forms where they required medications for their blood pressure or higher levels of oxygen. Patients also had fatigue, headache, low white blood cell counts, and fever as reported here. It's also worth noting that this, or understanding when to expect this CRS, because that's also really important. We really only expect to see CRS during the initiation of the drug. So that is why we use this slow ramp-up schedule where they start with a low dose and then on a weekly basis go up to the target dose. So this is the dosing that's used in with mosunetuzumab, and you can see the highest rates of CRS are going to be after that first dose. Even though it's small, it's the first time the patient will have seen the dose, and then again on day 15, because that's the first time the patient's going to be receiving that full dose of 60 milligrams. And so here, those could be days where we may want to watch patients more closely. What about the other bispecific antibodies with epcoritamab? The rates of CRS were slightly higher, 50%. Again, mostly grade 1. 32% of patients had grade 1, which was fever alone, and then grade 2 was 15%. The other less common side effects were similar to what was seen with the other bispecifics. And then lastly, and then when would we expect to see CRS with epcoritamab? This was the dosing schedule that you heard about previously, starts on a weekly basis. And so they start with a very small dose on the first week, a slightly higher dose the second week, and then the full dose is given on the third week. So that's cycle 1, day 15, and that's where the majority of different about epcoritamab, and you'll hear in a minute about glofitamab, is because of the high rates of CRS observed at this particular time point. It's recommended that patients after administration of the drug be observed in the hospital for CRS, so the patients can have close monitoring of their vital signs and monitoring for fevers. And so if patients do need treatment, they can receive this in a timely fashion. So this is similar with glofitamab. Glofitamab does have a 63% risk of CRS, but again, mostly grade 1, so 47% grade 1 and 12% grade 2. Compared to the others, there were a slightly higher risk of that more severe CRS, but the rates are still generally low. For glofitamab, the timing is a little bit different. Most of the patients had it after their first dose. The treatment for glofitamab patients do receive obinutuzumab, which is a CD20 antibody, prior to treatment, and that's to try to decrease this risk of CRS. And so that's given on day 1, and then the first small dose of glofitamab is given a week later, and that's when patients are typically monitored in the hospital for CRS. So it's really only after that first dose that we would need to monitor patients in the hospital. If patients do have bad CRS, they may need to go in again, and so that would be something that the physician would talk to the patient about. And as you can see in each of these slides, the rates of CRS as you go diminishes significantly and really isn't seen beyond the step-up dosing. So even though this may seem scary, it's worth noting that once you get beyond these first few weeks of dosing, CRS is very unlikely to occur, and the drugs are generally very well tolerated. And so what about neurologic toxicities? This is something that we worry about with CAR T cells. And we really didn't see the same neurologic side effects that are seen with CAR T with the bispecific antibodies. The term for the neurologic toxicity that's seen with CAR T is called ICANS. And you can see across these studies, when they tried to apply those criteria to the bispecific trials, the rates of these side effects were very low, on the order of 5%. Some other neurologic side effects were seen, like headache was very common, and that's why it does seem slightly higher with glofitamab and mosunetuzumab. But in general, we don't really anticipate significant neurologic changes with these bispecifics like we sometimes see with CAR T cell. And often when these neurologic toxicities were seen, they were in the context of CRS when patients may not be feeling well in general. I also just wanted to point out, because people are used to comparing CAR T and bispecifics, or even be trying to decide, should I have CAR T first or bispecific first, that the rates of CRS and neurologic side effects are lower with the bispecifics as compared to what we would expect to see with CAR T. So this is just a summary of the total CRS rates that we see with the different CAR T cell products, Tisa-cell, Axi-cell, and Lysa-cell, as well as the rates of neurologic side effects. So let's see. So if we see CRS, what do we do about it? So this does depend on the grade. If patients just have a fever, it's going to be very different than if they were requiring medications to support their blood pressure. Typically, if patients develop CRS, they likely have to be evaluated in either the clinic, or in the more severe forms, they may have to be monitored in the hospital. But we have a lot of treatments to manage this, and as you heard previously, we're getting better and better at managing CRS through our experience with these drugs and as well as our experience with CAR T-cell therapies. So we can use drugs like Tylenol, we can use steroids to quiet the immune system. We also have drugs to decrease the cytokine response. You may have heard of the drug tocilizumab, which can be used. And then we also have a lot of supportive care measures, like people may need oxygen briefly or medications to support their blood pressure. And so what about the role of the caregiver? I know there's probably some caregivers listening in on this call. So the caregiver, it's not required like it is in some types of therapies, but we still think it's a good idea to have help from family or friends, particularly during this ramp up period of time when the side effects, if they are going to occur, are at the highest risk. So a caregiver could really be helpful by, especially in these immediate periods after dosing, call the care team with any concerns. So if a patient did go home and infusion, or if they were in that very small percentage of patients to have any neurologic symptoms, that would be helpful to, of course, reach out to the care team. This is going to vary from hospital to hospital. Everyone's going to have different algorithms in place and guidelines for monitoring their patients, but it may be a good idea to monitor home temperatures for 2 days following the step-up dosing when the risks may be higher. And then it may be also helpful to help patients drive or support them in any way during this period when side effects can occur. Other considerations, while it's not mandated like it is with CAR T cells, it is also a good idea to consider remaining in close proximity to the treatment facility during the times of highest risk of CRS. So your doctor can help guide you on what days this may be the highest risk and the particular risk of the patient depending on the features of their lymphoma. And so that's something that you can ask about. And so lastly, I just want to take a minute to talk about follow-up care, and then we can dive into the questions. I know there's a few already building up. So for follow-up care, this is really going to depend on which treatment that you receive. You heard that there are differences in the duration of treatment depending on the bispecific antibody that's being used. Mosunetuzumab and glofitamab are of limited duration, so time-limited therapies where they're used for mosunetuzumab up to 8 to 17 cycles pending response, and for glofitamab up to 12 cycles, whereas epcoritamab is treatment that patients would remain on as a monthly basis once they get further out into their treatment. And so that's going to dictate how frequently the patient needs to come in for follow-up care. But if you're during the on-treatment phase, it's going to be important to check in with the team to look at ongoing side effects, even beyond that period of initial risk of CRS. There may be side effects. We might want to be aware of risk of infection, blood effects on blood counts, things of that nature, monitoring the labs, and then obviously importantly monitoring the response of the drug through periodic imaging. And then after treatment, it will be important to think about monitoring with the care team for potential recurrence. And then for some patients, particularly those with diffuse large B-cell lymphoma, if they've already had a lot of treatments, including CAR T, and then received treatment with a bispecific antibody, it would be worth talking about whether there any additional consolidation therapies like a stem cell transplant should be considered. So that's something you could discuss with your provider. So with that, I want to move on to the questions, and happy to take.
Great. Thank you so much, Dr. Crombie. I know Dr. Falke's been able to answer a couple of those via chat, but we'll get started with some of the other ones that hopefully will answer people's questions, and we have about 10 minutes here. Dr. Falke, one of our questions was, what is available if your lymphoma cells no longer express CD20?
That's a great question. I was actually looking at it and I said, like, that's a great question for discussion. These drugs are not approved. The approval of these drugs is not restricted to CD20 positive disease by label. And what that really means is that technically, you don't need to repeat a biopsy to show CD20 expression prior to starting that therapy. However, if a biopsy is done and CD20 expression is not there, I personally would have a little bit of a reservation to start a treatment like this. Even if CD20 were expressed somewhere else in the body, in other sites of lymphoma, having CD20 negative lymphoma, it's a little bit of a setup for not success for this drug. So I'm not advocating for repeating a biopsy for the purpose of showing CD20 expression, but in the presence of a biopsy that shows lack of CD20 expression, that would give me pause in considering a bispecific like this.
I got disconnected briefly. The question was just options for if it's CD20 negative.
Correct.
Yeah, I agree with what was said, and I think we're fortunate that there are other options available in relapsed refractory diffuse large B-cell lymphoma. There are some that target CD19, like loncastuximab, that may be worth targeting. Other clinical trials in development with trying to target different cell surface proteins. So I would try to focus on one of those if I had those options.
Great, thank you both. Dr. Crombie, what is your expectation for bispecifics to show up in the first line treatment trials?
Yeah, that's a great question. I think you heard from Dr. Falchi that there are a lot of clinical trials in development with the bispecific antibodies, and those trials do include bispecifics in the front line. I'm actually leading a trial here at Dana-Farber that just opened with glofitamab in combination with Pola-R-CHP that we're excited about. So I think it's too soon to say whether they'll definitively land there or not. It will depend on the outcomes of these trials, though I do like the idea of moving them to earlier lines of therapy in combination with other drugs so that fewer patients relapse and need them later down the line, or fewer patients ultimately need to go on and receive CAR T, for example. But I think it's going to depend on how well people do in these studies, how the drugs, we have seen some safety data already. There's been trials really of all the different bispecifics in the different frontline settings. So I think time will tell, but it's definitely being looked at.
Great, thank you. Dr. Falke, does bispecific-based treatments come with a greater risk of tumor lysis syndrome?
Great question. Like any other very active therapy for lymphoma, they can be associated with tumor lysis syndrome. In truth, however, we haven't seen tumor lysis syndrome a lot in the clinical trials. I don't see it in my clinical practice now that these drugs are approved. What I would kind of suggest is to think of these drugs much in the same way that you think about rituximab or obinutuzumab. If a patient is at high risk for tumor lysis syndrome regardless, then they're also at higher risk for tumor lysis syndrome from bispecific antibodies. And oncologists are pretty good at putting in place measures to mitigate that risk and to prevent it. We really haven't had issues with that.
Thank you. Dr. Crombie, why wouldn't bispecifics be preferred over CAR T?
That's a really great question, and that's one that's coming up all the time in the lymphoma community. How do we know how to sequence these drugs, and what order should, what's preferred, and why wouldn't we use this earlier? I think that you heard this a little bit from Dr. Falchi earlier. It's a little bit different for the fast-growing and the slow-growing lymphomas, at least the conversations that are going on in the field. I think for the diffuse large B-cell lymphoma, we have a lot of experience now with CAR T-cell therapy, and just recently have had the approval to move CAR T-cell to the second line for patients who are refractory to their initial therapy or have an early relapse. And I think in that disease, we have seen longer term follow-up and have seen really good outcomes for those patients getting CAR T early. So I think there's just some hesitation to put a single agent bispecific before a therapy that we have more experience with, and the disease can be aggressive. So right now that's being more commonly done in that order, just based on the kind of amount of time that we have had follow-up, and that so far CAR probably is a little bit more durable than what we've seen with the bispecific, but they haven't been compared head to head, so I say that with caution. With the indolent lymphoma patients, the follicular lymphoma patients, there's probably there's probably more flexibility in the way that we use the bispecifics, because patients do frequently have recurrences with time, and have more indolent disease. So they may get a bispecific, and then if their disease comes back, can move on to the CAR, or vice versa. If a patient says, I don't want to be wedded to continuous therapy, I'd rather get one treatment and then be done and do the bispecific later, I think the patient, there's more comfort in that, in deferring to the patient, or what the doctor thinks is best at that time in that disease. Though I think as we have more trials comparing different therapies head to head, or different combinations of bispecifics used earlier for aggressive lymphomas, things may shift, but that's, I think, how people are thinking about it now.
Great, thank you, Dr. Crombie. Dr. Felge, if bispecifics are not currently offered as a treatment option at a clinic or medical center where a lymphoma patient is being treated, how can they learn more or attempt to find out if this is an option for them?
Well, we just gave one option to learn more. um, Organizations like LRF are certainly an amazing resource to learn more about this treatment modality in general, lymphoma care. Um, I always welcome as many questions as my patients have, because as I showed, right, these are really complicated treatments that we sort of have to make digestible and understandable. So it's incumbent upon us as providers, and providers not means doesn't just means MDs. That this is nurse practitioners, physician assistants, nurses, etc. All of us provides beats of information that all of our patients kind of draw from to learn more of what's going on and what the options are. In a clinical trial, there's something called an informed consent document that you're given that usually has a lay language, description of the study, and includes some information about this bispecific antibodies. I always recommend when one wants to learn more about a treatment, particularly a newer treatment, really kind of stick with the sources of information that have the most experience, and they're the most authoritative. And LRF is one of them. Other peer organizations are similarly good. Um, as cancer center websites usually have a lot of good information, and there is never any question that doesn't make sense or is inappropriate or is silly or anything like that. All questions are good questions. Our first job is to clear up those doubts to the best of our ability.
Great, thank you so much. Dr. Crombie, this person asked, are bispecific antibodies effective against central nervous system lymphoma? Is the molecule small enough to penetrate the blood-brain barrier?
That's a really good question. I'm not sure I know the answer. I think most of the clinical trials have excluded active CNS involvement, which is typical when first testing drugs. I will ask Dr. Falchi if he's aware of any reports that these were active. It may be something that is studied in the future.
I apologize that I missed the first part. Could you repeat, Jess?
Sure. Are bispecific antibodies effective against central nervous system lymphoma? Is the molecule small enough to penetrate the blood-brain barrier?
Got it. Yeah. Well, the short answer would be we don't know, because those patients unfortunately were excluded from all clinical trials. Our common understanding is that, and I showed you that, like the molecule is structurally very similar to rituximab. Rituximab doesn't go meaningfully in the CNS, so we wouldn't expect these drugs to really penetrate. So the answer is that the molecule is a little too large. That being said, again, we don't know, because not only patients were excluded from clinical trials, but also the what's called the CSF, or the fluid around the brain that we usually sample with a lumbar puncture, that was not done routinely in the clinical trial. So we actually have no idea if these drugs are ever found in the brain space. At the moment, if somebody comes with, unfortunately, lymphoma, especially diffuse large B-cell lymphoma, anywhere in the brain space, if bispecifics are an option, that they should be paired with a CNS-directed therapy or brain-directed therapy. I think it would make it a little tricky, and I think at that point, the plan of care would be a little bit more nuanced. But bispecifics alone would not be my recommendation.
Great, thank you. We have time, I think, for just maybe two more questions. Dr. Falchi, are each of the bispecific options single treatment options, or can they be used again in a relapse case scenario?
So the experience in the clinical trial, particularly the mosunetuzumab and the glofitamab clinical trials, told us that if you had a very good response to a bispecific agent, you stop it, and then after a while, disease comes back, you can potentially reuse it, and there is a decent chance of reobtaining a response. My personal approach to this is if disease comes back after a response, I would want a new biopsy, understand why disease came back, and make sure that there isn't any other potentially more appropriate or more promising alternative. Most of the responses that we've seen are long-lasting responses. So if a disease comes back, perhaps follicular lymphoma may be acceptable. Diffuse large B-cell lymphoma, I'd think really hard before restarting a bispecific antibody.
Thank you so much. And Dr. Falchi, I think this is related to one of the slides you talked about, but someone had asked, did the tumors in the CAR T-cell responders in the bispecific AB studies have any common characteristics?
That's actually, I actually saw that question. I thought that must be an investigator or somebody, because that's a really sharp research question. So my gut feeling is that the answer is yes. And I'll give you an example. There is a mutation in a gene called P53, that usually when we find it, it indicates a disease that's, and I'm talking about large cell lymphoma now. It indicates a disease that's a little bit more stubborn, more difficult to treat. Turns out the patients with this particular mutation had a lower chance of success with both CAR T-cell and bispecific antibodies. It can be chance. I don't know, and I think nobody knows what the kind of biological underpinnings of this are, but we do find in our clinical practice, at least in my clinical practice, I'm curious about Dr. Crombie's, that those same cases where we have a hard time getting through with CAR T cells, we also have a hard time sometimes getting through to bispecific antibodies. It doesn't mean that they shouldn't be used, and we have plenty of examples of patients who did not do well with CAR T cell and then did well with bispecific antibodies. But there certainly is some common traits biologically on a disease for which immunotherapy may just not be, you know, the answer or the final answer, and maybe we should explore other treatment, alternatives that don't rely on immune therapies.
Great, thank you so much. And Dr. Crombie, just to end on our last question, someone asked, do you foresee bispecifics being prescribed at a broader set of cancer centers, or mainly just the large cancer centers where chemo is widely available, CAR T and stem cell is not? And this person asked, but with a longer and more frequent treatment cycle, how should people not living near a treatment facility think about this as an option?
That's a really important question as we think about using these drugs more broadly. I think, right now, as they are very new, they may start initially at the larger cancer centers, but I imagine the goal is that smaller cancer centers will gain comfort as well. We saw this with other drugs, like even other immunotherapies started out at larger cancer centers and then made their way to smaller ones. Even CAR T cell is still at larger cancer centers, but there are some smaller ones that are doing this now as well. One thing that also may happen is that patients may be required to come to a larger cancer center to do the step-up dosing. That's when we expect to see the highest risk of toxicity, and then can return to their local oncologist to continue on with the more regular dosing once they're out of that window. That's something that still hasn't rolled out yet, but that's something that we've been discussing with our satellite sites at our program. So I imagine other places will hopefully come up with some system that works where patients can safely receive these drugs closer to home and have access to them. But I think we need a little more time for everyone to figure them out since they are relatively new.
Great. Well, thank you both so much, Dr. Crombie, Dr. Fauci. This has been a wonderful program. We had a lot of listeners, a lot of great questions. Hopefully, we got most everyone's answered. And this is being recorded and will be sent to you via email in case you'd like to review any of the information that was spoken about today and pause it and rewind as you'd like. And we'd also like to thank our sponsors of this program, AbbVie and Genentech, for making this program possible. And then please remember, if you have any additional questions, you can always reach out to our LRF helpline at 800-500-9976. At the conclusion of this program, you'll be prompted to complete a program evaluation. Please take a few moments to do this so we can incorporate your feedback into future programming. And with that, I'd like to thank everyone for joining us today, as well as our expert speakers, and for everyone to have a wonderful day.
Thank you.